Thank you, Ariel. Good morning. Thank you, Seyes and Patricia Sila, for giving me this opportunity for representing the Latin American Society of Endoscopic Surgery. It's a pleasure for me to represent Dr. Luis Romagnolo, who works as a surgeon in Barretos Cancer Hospital. You're welcome, Luis Gustavo.
Good morning, everyone. Thank you for the kind invitation. I hope that everybody here survived last night. It was amazing. So today I will talk about a little bit about emergent care. It's not for parastomal hernia. It's not an easy topic, but I try to identify and show for you some ideas about what happened and how we can fix this problem. So the first question about this is my disclosure, is the first question is, do you know what technique do you use to emergence for parastomal hernia? If you ask for anybody here, everybody talk, okay, this technique, that one, another one. So there is no consensus about which one do you use because technically sometimes it's difficult. You have so many morbidities associated, maybe some infection. You have maybe more than 50% recurrence, and sometimes it's not possible to do in a minimally invasive surgery. So when I'm looking for some papers and some guidelines talking about what we can do in emergency parastomal hernia, I try to find some ideas so nobody knows which technique you can use and how we can fix this the best way. There are so many techniques and so many possibilities to do. Laparoscopy, robot, open, there's so many techniques. So the idea is how to prevent, how to associate techniques to avoid kind of problem, to avoid this emergency. Because the most of patients that arrive in emergency, they have pain, they have fever, they have some infection, to change the position of the stomach, local stoma. So there are some algorithms to follow. So I think that it's nice to understand that reverse if possible, repair when have symptoms, and watchful waiting when you can. This is some ideas that we have to understand about. If you detect it's an emergency, yes, okay, treat it open, depends how you can use it. Laparoscopy, you have to choose. If no emergency, you have to identify if you reversible or not. And we have to think how to do this. So some people, when you have parastomal hernia, they have some midline hernia, a little bit small. Sometimes it's large. So when you have a large or moderate midline hernia associated, you have to try to minimally invasive surgery, robot, and laparoscopy sugar baker when you have a small midline hernia. So what I brought for you here, some videos talking about what we used to do in the past and how we are doing now. So this is in the past, we used to do a keyhole. Why? Because it's easy to understand, but using the robot, you can use the pass suturing there to close the defect. And if you look here, I can show here this pass suture here just to close to help me to close the defect first, and after that we finish the let me look forward here. I cannot use the mouse. Yes, gotcha. Look, where is the, okay, here. So finish this using this suture to fix. I close the defect, and it's much easier to close after using the Barbie suture. So I use this just to help me, and using the Barbie suture to close. And after that, we can use the mesh to fix and use some suturing, close the colon here to avoid slide here. So this is used in the past. But what's the problem about this? This kind of technique, the problem is recurrence, and the evidence show that if you have to open the mesh, you have more problem. So the idea is you have to use the technique that cannot cut the mesh. So you have to do a hole in the mesh. So the sugar bake technique, it's a good one to do this. But what's the problem with sugar bake technique? The angle that you do when you put the mesh. So to avoid this kind of problem, you have to avoid this angle that I'm showing here, because it is problem to, after you have to irrigate the stomach or have some kind of obstruction. So this angle you have to avoid. So the problem is, I brought for you a case that my friend Eduardo Parra gave to me, just to show this is an emergency patient with pain and came for the emergency. And the first is, this patient has so many adhesion. It's very common about this. So you have to release the adhesion first to detach all the adhesions to avoid this kind of pain. And after that, you have to, here, identify the hernia sac, detach the hernia sac, and after that, we have to close the defect. You have to put the colon close to the wall, like this. Just to put the best position for the colon, to lateralize the colon. And after, when you finish this, you can put the mesh. And use some tuckers just to, use some tuckers just to help you here. Yes, gotcha. Yes. And the suturing. So you can use the suturing for all the wall here, just to detach, just to fix the mesh. And the sugar baker technique is done. So we believe that this is the best way to treat the patient with the parastomal hernia, no matter if you have emergency or not, but you can use the long stitch. It's a running suturing, and the tucker just to keep the mesh in the real position. So thinking about this, we have to talk about not only about this, but about prevention. If you use a prophylactic mesh to prevention parastomal hernia. So sometimes it's not good because you have no evidence that prophylactic mesh could be good one, but we have some papers that talk about you can use to avoid, but some problems with hernia. So when we talk about this, we have to think what kind of mesh we have to use for prevention. The biologic mesh, or you can use some special mesh, that's synthetic mesh. So we have to think about how to prevent. In Latin America, the problem is the cost to use the mesh for all the procedures as a prophylactic. So in summary, our idea is the surgical treatment for parastomal hernia is a complex case. You have to think what kind of patient you have to use this kind of technique as a robot or laparoscopy. You have to have experience to do suturing in abdominal wall, to fix the colon, to avoid the recurrence. The robot assistant can help you a lot about this kind of procedure. And the technique is not a consensus, but we believe that the sugar baker technique could help us to avoid some problems and the best way to avoid the recurrence. So that's it. Thank you.